My first slide is just a couple diagnoses that it's a chronic persistent disorder of the mental process caused by the brain disease or injury, and it's marked by memory disorders, personality changes, and impaired reasoning. These are the definitions right out of the dictionary. Cognitive decline from a previously high level of functioning and impairment of memory in 2 or more cognitive domains, either your orientation, you know, what day is it? Where are you at? Your attention, your language, that's your speaking and word finding, visual spatial functions, executive functions, motor control, and praxis. So, I mean, that's a lot of information there, probably more for clinicians than patients, but these are people like who normally could drive to the store, but then they took a different route and they got lost. That's a concerning symptom of dementia. And it's preferably established by clinical exams and documented by the neuropsych testing. Deficits should be severe enough to interfere with activities of daily living. There's quite a few types of Alzheimer's disease. I've already looked at the next presenter, and I think he'll talk a lot more about them. Alzheimer's disease, far and above the most common, over 60%, probably 80% of cases. Vascular dementia, mixed dementias that can overlap. Dementia with Lewy body, which you've already heard a few people mention. Frontal temporal dementia, Parkinson's disease dementia, progressive supranuclear palsy. These are much more rare, but we do see them. Cortical basal degeneration, multi-systems atrophy, and Huntington's disease, which is a genetic condition. Less common types, but ones that you can see that are, I would almost say kind of self-induced with the alcohol and a chronic traumatic encephalopathy. These are the NFL football players and the boxers that had repeated head injuries. She already talked about the normal pressure hydrocephalus. We learn in medical school, this is like swollen ventricles and people are incontinent of urine is one additional symptom for this condition. Chronic subdural hematoma, and then central nervous system infections like HIV, AIDS, and then prion disease, which is that Creutzfeldt-Jakob, you know, from eating prions in cattle in Europe that was on the news. So some signs when patients report memory loss, it doesn't always correlate with dementia. I have many patients who have told me for the past 10 years that I've been practicing in Valley City that they're forgetful. Their family has never said they're forgetful. I mean, I listen to them, I get neuropsych testing on them, but usually these people are okay. It's the patients who don't think they have a problem, but their children or their spouse is saying, you know, my wife repeats herself, or she can't remember things I told her, or she has to write down appointments. Those are the patients that usually have dementia. Because people that like forget that one word on our 3 questions, you know, like boat, house, chair, but then I come into the room 5 minutes later and they're like, oh man, doctor, I forgot that 3rd word. I mean, they're less worried about those patients than the patients who go on their day-to-day and don't realize that they have a memory problem. So forgetfulness is the #1 thing for dementia that I think we all know that people with dementia are forgetful, but also retaining new information, handling complex tasks. Like I ask patients, do you still balance your checkbook? Do you pay your bills? Do you do your own grocery shopping? Or does your family help you? Reasoning, are you able to cope with unexpected events? Spatial ability and orientation, that's at getting lost in familiar places. Language is word finding and behaviors. And she had mentioned some mood changes also in her talk, the first speaker with those top 10. So what happens when patients come into the office for the first visit? I kind of want to tell a quick story here. I got a new patient last fall. I'm going to kind of be vague on the description, but about an 80-year-old gentleman ER follow-up, patient ran out of gas and tried to run home. Running home to him was his old house, not the apartment he currently lived in. Fell and came into the emergency room. And then I was seeing them in follow-up, also has other health problems, uncontrolled diabetes. And the first questions I asked, like, well, to the family, when did you notice memory problems? And it's usually years. Oh, we've known for years, but see, mom always took care of dad, and now mom's in the hospital. So, you know, that's one thing. And is it getting worse? Is there any behaviors? How's his sleep? You know, just kind of getting that information. Are they still driving? Is somebody with them 24/7? This is kind of what we have to decide and figure out as a primary care doctor. Then we do our physical exam, you know, to find out if there's any changes in their eye movements, their reflexes, weakness, have they had previous strokes? And then it gets to cognitive testing. There's a lot of stuff to get into your first initial visit, which is why someone like this will say, let's address the acute concerns and come back another day and keep working on this dementia, or get you referred for the neuropsych testing. So the screening tools are like that mini mental status exam, the depression screening tools. Those are questions we ask people in the office. And then there's more complex screening. That's the neuropsych testing that our last speaker was talking about. And then sometimes we do lab work just right off the bat. Like this person, I knew I was going to have to check them for how's their diabetes doing, since it hadn't been checked for several months. These are labs that we routinely do, like a B12, a CBC, a thyroid check. We consider syphilis testing if at risk. I mean, you'd be surprised how many soldiers were in Vietnam and might have, you know, picked up infections that could be, you know, bad down the road. Folate is another vitamin level if somebody has alcoholism. Calcium levels, they can increase in cancers. They can cause confusion. Other electrolytes and kidney disease can cause confusion also, like low sodiums. Some of those things are more of an acute thing, not a chronic. You know, over 2 years, I would hope your sodium isn't low. But I also wanted to add here, because I did, you know, talk with one of the neurologists. If it's a rapidly progressing dementia, we order another thyroid test called a TPO antibody and an autoimmune encephalopathy panel. But this is getting into specialty care. So if a primary care doctor doesn't order this, I wouldn't fault them. I think we're looking mainly, like, the specialists want that basic workup because they probably get an hour with these patients. And then imaging. In this patient, I got a CT scan because I could get one quick and easily. Eventually, this patient did get referred on to neuro and got an MRI. And so MRI, because it's more sensitive and less radiation, but it's also harder to get. It's not available every day. It's more expensive. You have to lay still. If you're claustrophobic, you can't have one. My dad had to be sedated to have an MRI for an ear thing one time. So it happens that it's just not as easy of a test to get. But if you do get an MRI, you don't need contrast to look for the neurodegenerative changes that we see in dementia. But if you're worried that your patient might have some kind of infection or cancer causing the memory change, then you should get contrast. CTs would show the things like a chronic subdural hematoma or a subacute one. This is like when a patient was fine, they fall, and like 2 weeks later, they start having memory problems. That's usually not dementia. So those are the things you pick up on a CT. Probably someone who's had dementia for 3 or 4 years, you're not going to find any treatable things, but it's still worth looking. People can have cerebral hemorrhage, which is a brain bleed. Again, that condition, normal pressure hydrocephalus. Cancers can even show up on CTs too. Cerebral atrophy, which is just kind of weakening of the brain tissue over time, shrinkage. And then ischemic cerebral vascular disease. This is the history of strokes, the smoking, the high blood pressure that can cause some little micro changes in the brain. And then also micro hemorrhages, which is little bits of bleeding, can be seen in something called cerebral amyloid angiopathy. And I've actually had a patient that had these, and that was one of their symptoms or one of their findings of their dementia, which we already knew they had. Rarely other testing is needed. I think I saw a question in a chat about the PET scans or the SPECT scans. I don't order those. Neurology may order them. I don't see them ordered very often at all. A lumbar puncture would be putting a needle in the spine and collecting fluid. You'd really be looking for infections or abnormal proteins or maybe even something like multiple sclerosis if you were doing those kind of tests. And a brain biopsy is also very, very limited. And that would probably be for that like prion disease that's very rare. So referral, who should we refer? Younger patients. I got to refer to my list here for, let's see. I guess I said all I want. So especially younger patients who are rapidly progressive, try to get those people into a neurologist as soon as you can. Neuropsych testing as soon as you can. Sometimes it takes a while to get into a neurologist. When there's other neurologic conditions like the Parkinson's disease and Huntington's, it used to take like almost a year to get someone into the neurologist. Now it's getting much better because there has more availability. But again, I put on here, primary care does have the advantage of having the serial observations over months and years to keep working with the patient and the family, because there's a lot of education that the family does need for Alzheimer's and being caregivers. And that's where the Alzheimer's Association comes in and can be very helpful for primary care offices. I just put a few of my references in here from the American Academy of Neurology and up to date. And I think I have a few minutes left. I wanted just to cover a few more things. For the sleep apnea, not everybody can use the CPAP machine. I have found just putting people on oxygen at night has greatly improved some people's memory. You can't order oxygen for sleep apnea because you're supposed to use CPAP, but you can order it for heart failure or COPD. And I've seen people get a lot more clear with just oxygen at night. I've seen people do better when they go to assisted living and they have that social stimulation and 3 meals a day and their pills all like they're supposed to take. And when a patient comes in and complains about memory loss or confusion or a family, I could probably give you 20 examples off the top of my head of medications causing confusion, which is more of that mild cognitive impairment that's actually treatable. One of the biggest medications, and I hope there's not a bunch of patients on the call that are going to be upset and calling their primary cares tomorrow, but gabapentin and Neurontin for chronic pain and Lyrica. I will not even send anybody for neuropsych testing probably if they're on high doses of that, because once they wean down, they do a lot better. I mean, it's right in the list of side effects. I had one patient, he played poker with my husband, and my husband knew he's my patient because the guy told him, and you know, I don't talk about this stuff at home, but my husband said, what is the deal? He can't play poker anymore. He just, you know, something's wrong with him. And he was only in his 60s. Well, we sent him off neuropsych testing, and we found out his Mirapex for restless legs. The guy stopped Mirapex. He still takes Aricept, that's diazepam for mild cognitive impairment. But it was just remarkable how, like, here he had all this trouble, like, with numbers and playing cards. And so be it, you know, rule number one, blame the medications, but you really should look at your patient's medications when they come in for a visit. Other neuro tips, I have to mention driving. Driving concerns. You ask the child or the, you know, usually it's a child, a spouse, usually says, well, I do the driving, but when they're widowed, you're like, would you ride with your parent? Would you let the grandkids ride with your parent? So you need a lot of help from the family on this driving. And a lot of times, you can refer to OT to do a driving eval, but I a lot of times just talk to the patients and their families, and I get them to repeat their driving test through the DMV. And if they fail that test, then they've failed and they cannot drive, because it is a difficult conversation. I've had patients leave my practice over the driving issue. But if I've already sent it off to the state and they don't follow through, then they're essentially driving without a license. They have so much time to take the test. I think I pretty much covered a lot of stuff. I hope I left a little bit of time and tried to catch up. I know I talked fast. Oh, last thing, avoid benzodiazepines and narcotics, opioids if you can.